hypertrophic myopathy, and alcoholic myopathy. Hypertrophic myopathy is very common and can affect people of any age. It is a common cause of sudden cardiac arrest in young people, including the young athletes. The hypertrophic myopathy occurs if heart muscle cell enlarge and cause the wall of the ventricle, usually the left ventricle, to thick. The ventricle size often remains normal, but the thickening may block blood flow out of the ventricle. If this happens, the condition is called the obstructive hypertrophic cardiomyopathy. Sometimes the septum, the wall that divides the left and right side of the heart, sink into the left ventricle. This can block the blood flow out of the left ventricle. Then the ventricle must work harder to pump blood. The symptoms can include the chest pain, dizziness, shortness of breath, or fainting. The hypertrophic myopathy also can affect the heart's mitral valve, causing the blood to leak backwards through the valve. Sometimes the thickening heart muscle doesn't block blood flow out of the left ventricle. This is referred to as a non-obstructive hypertrophic cardiomyopathy. The entire ventricle may thicken, or the thickening may happen only at the bottom of the heart. The right ventricle also may be affected. In both obstructive and non-obstructive hypertrophic cardiomyopathy, the thickened muscle makes the inside of the left ventricle smaller, so it holds less blood. The wall of the ventricle may stiff, and as a result, the ventricle is less able to relax and fill with blood. This can raise blood pressure in the ventricles and the blood vessel of the lungs. Change also occurs to the cells in the damaged heart muscle, which may disrupt the heart electrical signals and lead to arrhythmia. Some people who have the hypertrophic myopathy have no signs or symptoms, and the disease doesn't affect their lives. Others may have severe symptoms and complications. They may have shortness of breath, serious arrhythmia, or an inability to exercise. It is rare, but some people with hypertrophic cardiomyopathy can have sudden cardiac arrest during the physical activity. The physical activity can trigger dangerous arrhythmia. Hypertrophic cardiomyopathy usually is inherited. It is caused by a change in gene in heart muscle protein. Hypertrophic cardiomyopathy also can develop over time because of high blood pressure or aging. Diseases such as diabetes or thyroid disease can cause hypertrophic cardiomyopathy. However, the cause of the disease is unknown. Since the initial description of hypertrophic cardiomyopathy, the feature that has attracted the greatest attention is the dynamic pressure gradient across the left ventricle outflow tract. The pressure gradient appears to be related to further narrowing of the already small outflow tract. The already narrowed by the marked asymmetrical septal hypertrophy and possibly by an abnormal location of the mitral valve, by the systolic anterior motion of the mitral valve against the hypertrophy septum. Three explanations for the systolic anterior motion of the mitral valve have been offered. The first, the mitral valve is pulled against the septum by contraction of the papillary muscles, which occur because of the valve's abnormal location and the septal hypertrophy alter the orientation of the papillary muscle. Second, the mitral valve is pushed against the septum because of abnormal position in the outflow tract. Third, the mitral valve is drawn toward the septum because of the lower pressure that occurs as blood is ejected at high velocity through the narrow outflow tract. This is the Venturi effect. So for most patients with the hypertrophic cardiomyopathy have abnormal diastolic function, which impair the ventricular filling and increase filling pressure, despite a normal or small ventricular cavity. These patients have abnormal calcium kinetics and subendocardial ischemia, which are related to the profound hypertrophy and the myopathic process. Signs and symptoms: palpitation, dizziness, shortness of breath, chest pain. Hypertrophic cardiomyopathy is diagnosed based on the medical history, the symptoms, and the family history. A physical exam, a echocardiogram result. Additional tests may include the blood test, EKG, chest X-ray, exercise, stress test. Cardiac catheterization, CT scan, and MRI. Treatment of the hypertrophic myopathy depends on whether there is narrowing in the path that blood takes to leave the heart, how the heart is functioning, and if arrhythmia are present. Treatment is based on preventing symptoms and complications, and include risk identification and regular follow-up, lifestyle change, medications, and procedures as needed. No specific laboratory blood tests are required. Two-dimensional echo may be diagnostic for the hypertrophic myopathy. Findings may be summarized as follows: abnormal systolic anterior motion of the mitral valve, left ventricular hypertrophy, left atrial enlargement, small ventricular chamber size, septal hypertrophy with septal to free valve ratio greater than 1.4 to 1, mitral valve prolapse and mitral regurgitation, decreased mid-aortic flow, partial systolic closure of the aortic valve in mid-systole. Cardiac MRI is useful when echo is questionable, particularly with apical hypertrophy. EKG findings may include the ST wave abnormality and the left ventricular hypertrophy, axis deviation, conduction abnormality, sinus bradycardia with ectopic atrial rhythm, atrial enlargement, abnormal and prominent Q wave in the anterior precordial and lateral limb lid, short PR interval with QRS suggestive of pre-excitation, atrial fib, and P wave abnormality. The following diagnostic modalities may also be useful: the cardiac catheterization to determine the degree of outflow obstruction, cardiac hemodynamics, the anatomy and the diastolic characteristics of the left ventricle, and the coronary anatomy. Pharmacology therapy for the hypertrophic cardiomyopathy may include the following: beta blocker, calcium channel blockers. To lower the blood pressure, the ACE inhibitor, angiotensin II receptor blockers, beta blockers, and calcium channel blockers are examples of medicines that lower blood pressure. To slow the heart rate, the beta blocker, calcium channel blocker, digoxin are examples of medicines that slow the heart rate. Beta blockers and calcium channel blockers also are used to lower the blood pressure. Amiodarone. To avoid the inotropic drugs if possible, avoid nitrate, avoid digitalis, use diuretics. Surgical and catheter-based Therapeutic options include the following: left ventricular myomectomy, mitral valve replacement, permanent pacemaker implantation, catheter septal ablation, placement of an implantable cardioverter, defib, heart transplantation. People who have the cardiomyopathy but no signs or symptoms may not need treatment. For others, treatment is needed. Treatment depends on the type of cardiomyopathy, the severity of the symptoms and the complications, and the age and overall health. The main goal of treating cardiomyopathy include managing any conditions that cause or contribute to the disease, controlling signs and symptoms so that you can live as normal as possible, stopping the disease from getting worse, reducing the complications and the risk of sudden cardiac arrest. Treatment may include lifestyle change, medicine, surgery, implant device to correct arrhythmia, non-surgical procedures. Okay, in this case study, the family study in the 1980s led to the discovery of the disease causing the mutation in genes encoding sarcomere proteins. Currently, a candidate gene strategy is used, and analyzing the sarcomere genes and the limited number of genes associated with metabolic storage and the mitochondrial cardiomyopathy that may mimic the hypertrophic cardiomyopathy but require different management. Sarcomere mutations are found in 60 to 70% of adult and pediatric patients with a family history of hypertrophic cardiomyopathy. More than 1,000 distinct mutations have been identified, and most are unique to a specific family. Mutation in myosin head chain and myosin binding protein C are most common, collectively accounting for 80% of sarcomeric hypertrophic cardiomyopathy.